notes and hand it over to Dr. Child. Thanks so much for being here.
All right. Good afternoon. Few disclaimers. So as we plan these things, it's usually 4 to 6 months in advance. So I'm actually traveling, and that was semi-intended, semi-unintended. So um, if every now and then you see my background change to the back of a car, that's because I'm traveling. Um, Second, this is guided towards back issues in the summer months, but of course, I know a lot of people probably tune in because they have back issues and we want to sort of address sort of their concerns and needs as well. So, second part of the talk, if you want to tune in or out, is more devoted towards common back issues and then that will lead into um, sort of some of the things that some of you might be going through. So I'm going to get it started. And then Natasha, I don't see the questions, so if you could field those when it comes time.
Yes, we'll do.
All right. So we're going to talk about some typical things and typical problems, as well as some of the normal anatomy, some of the normal problems and treatments. But again, we're going to try and focus on the intent of the talk, which is back pain, back uh, R&R summer months. But of course, this is Tahoe, so summer, winter, both active times. Um, so, first of all, I want to sort of get out there that with people's problems, and we see this a lot in clinic, you know, groans, creaks, strains. A common question I get at least every clinic I have is, when I move my neck, I get this popping. I can hear it. It's almost really loud. Or I did something and I heard my back pop, snap, crack. That's the human experience. We all get those. Every time I walk up the stairs with the lights off at home, I hear my knees as if I'm got two springs for legs, and that's just who I am, and there's nothing wrong with that. Um, Sprains and strains, oh, I threw my back out, I threw my neck out. Also, par for the course. It's part of who we are, and every neck, every back goes through it. And then even the, oh my God, I think I wrecked something. I really did something. And now I'm in the throes of horrible back pain, which can be bad enough, get you an emergency room, to get people mobilized, treating you with medications. That also will happen to a good number of us. And is actually pretty normal. Ask any emergency room physician. It's very common. And one of the challenges we have is that if we want to talk about what's causing your pain or your problems after whatever you're doing, and it may be Tahoe activity, or it may be I went out to get the mail, or I dropped my keys. The challenge we run into is that there's a lot of things that make up the spine. There's obviously bones, there's discs, there's ligaments, there's the nerves that are associated with the spine and spinal column. There's the muscles, ligaments, all these interconnected soft tissue structures which help support your spine, which really mobilize the spine, because obviously a skeleton by itself doesn't do really anything. Um, and so all these things and 20, 30 other things I can rattle off the top of my head are why we end up in this predicament. And so um, the challenge we have is that we can only non-specifically wave our hands and point towards what may be causing your back pain, but oftentimes it's actually very hard, if not impossible, to put our finger on what's causing exactly your back pain. Um, and so we kind of focus on some common things. And if we want to keep this evidence based, which is sort of the way I live my life, we can say that A lot of this is really intuitive. Your mom's nodding her head right now and saying, sit up straight, have a straight back, eyes forward, shoulders back, because these things are known to decrease stress on the back. And people who have these issues often have to have that inner mom in their head saying, do all these things. And the data supports it that these modifications, especially if you have these jobs that repeatedly load your spine in a certain way, that making modifications to your work is really helpful. Um, there's been some work done by people who study motion disorders. Probably the most familiar to a lot of you is Parkinson's disorder, and that is a motor disorder. Many of my patients have Parkinson's disease, and they'll tell you that they have a tougher road to hoe. Their muscles, their joints, um, have more um, issue recovery, healing, etc., because they don't have all the normal accessory muscle control that we have, which help decrease the load on our spines. And so they've done studies where trying to teach them or teach other patients these postural biofeedback mechanisms on how to recruit their extra muscles, how to maintain positions that help recruit these muscles, that actually decreases their pain. And so if we apply that to us, it's that, um, you know, learning to mobilize good posture, core strength, the things that keep you healthy do help. And that's evidence based. Sometimes we'll actually send you for these things. Of course, nowadays, the internet, chat GPT, everything's rife with showing you regimens or exercises. And of course, one of the core multimodal non-operative care maneuvers we'll do when you come into our clinic is send you into physical therapy. And this will be familiar to every one of you that I've sent to therapy or have done therapy. And what they're basically trying to do is activate all those accessory stabilizers to help you and help your pain. Moreover, people that have back pain, back problems, or even those of you that don't, would be well served to learn these things, to work on your core strength, to work on postural stabilizing exercises, because those are the things that will keep you from injuries. And I often tell patients, look, if you don't have any back problems, any neck problems, it's on you. You can do whatever you want. Of course, you could do this stuff and that will benefit you. But if you do have these problems, I'm going to send you to therapy, not to take a class where you get an A or a B, but to learn things that you're going to take with you every day for the rest of your life. And so it is something that's going to be more part of your regimen. My patients will get up in the morning, they'll do their exercises, maybe even after a hot shower, and they're ready to go. Hugely beneficial. Um, so one of the other problems, and another common thing I'll see in my clinic is people be like, "Ah, pain is right here, right between their shoulder blades." And I'll typically first think, oh, what's going on with your neck? Or they'll tell me, the mid back, or it's not their low back, it's not their neck, it's their thoracic spine. And, the spine's a dynamic thing, nerves that are routed and wiring that's, way more complicated than the wiring on this RV that's parked in front of me. So where you report your pain, where you feel your pain, isn't necessarily where your pain's coming from. And that can be an added challenge for me. There have been studies that show people who have a lot of pain get stuck. They have reduced mobility, especially in the thoracic spine, and they'll assume this bent posture for a host of reasons, one of which is stenosis, which we'll get to later, Another is lesser recruitment of the muscles, which are fatigued, which aren't supporting you anymore. Um, and so a lot of what we'll work on with therapists and other ancillary care is strengthening those things, building those things up so that you have that baseline foundation for your home, which is your body. Um, and again, I think everyone often knows this and comes to the clinic expecting that, oh, I know I got to work on my core. Core strength is important. And all of the major modalities that you're going to be sent to for physical therapy for these back injuries, sprains, strains, etc., are going to be variations of core strengthening. Um, that 2009 McGill paper sort of codified the big three, but there's, like I said, there's a host of other things, and that may be a class you need to go to and will study up on for the rest of your life. Um, so we're here to help you. There's plenty of other great therapists in our region, or if you're out of our region. Um, and it may take a few hits and misses. I've found that patients really do connect with some therapists, not others. When they find their therapist, they become really sort of devoted to them. But you may need to not necessarily go with the first one. And some people may sleepwalk you and just put you in a corner with a rubber ball, and that may not be the therapist for you. Um, Other people are self-starters, but I'll vouch for our guys. They're great. And, to that measure, I would vouch for everyone in the community. There really is a great host of therapists, both in the system and outside of the system. So we also are a unique group. I've worked other places, and certainly this isn't uh, metropolitan, rural, or suburban Texas, which is the last place I worked, or a big city like Seattle and Boston, also places I've worked. Tahoe is its own animal, and so I often have the added challenge of, oh, so you have back pain. Oh, so you're an avid mountain biker or snowboarder or paraglider. Oh, and you're 75 and you want to keep doing those things. Um, that's what we're here to help you through. Um, because not always are these just regular sprains and strains. And when you have these significant episodes, injuries, you may need more than that. Just a run through of the last couple weeks or months. First picture up is a cervical facet dislocation. So this is a 35-year-old tech worker who was spring skiing and dislocated his neck. So literally came within a few centimeters, millimeters, roughly on the order of 4 to 6 millimeters from quadriparesis. Um, Here's a young lady who was recently wakeboarding and had a sudden acute disc herniation, which nearly completely occluded her cervical canal. And unfortunately, all she had was some scant weakness. Here's somebody who recently rolled their motor vehicle and very nearly ripped their spine in half. You can see this fracture that rips through the posterior bones, the bones you feel on your back, all the way through the anterior spinal column, yet left the spinal cord intact and unaffected. It's a real win for him. And then here's a more common insufficiency fracture, which um, happened from fairly benign normal activity, but caused this burst type pattern with posterior bone that wants to squish out towards the spinal cord. Thankfully didn't. And I didn't show you anything that ended badly because It's generally not the types of things you want to dwell on, but of course they happen as well. Um, just a brief tour through what happens when these things happen. That first patient had an unstable spine, so we stabilized his spine, and that's an anterior cervical fusion. Um, Second patient with the big disc herniation, we removed that, took all the pressure off the spinal cord, and because of her young age, performed an artificial disc replacement. And in 6 to 12 weeks, we'll be back wakeboarding. That third patient that, like I said, nearly ripped his spine in half. That patient was stabilized with what's called percutaneous instrumentation through the skin, not a big formal surgical approach. Um, and then that third one that or the fourth one that burst fracture had also a posterior type fusion, but maybe a little bit more standard of an approach. Um, but back to sort of more mundane things. How do we mitigate injury? So a lot of this is fairly intuitive, but one concept I would help you guys with is the body likes to be within what we call a cone of economy of motion, meaning too far out of that cone from your feet to your head, and it just takes too much work for the body to maintain balance, to stay um, upright without much additional work. And too far out of that, and people suffer. They have a lot of pain. So again, shoulders back, head up, stand straight will minimize that through your activities. Modifying your workspace, modifying the things you're doing so you're not constantly struggling or looking down, etc. That's my big fault. It's my job involves me staring at somebody's back through magnified telescopes for sometimes hours at a time, and yeah, I feel it. And then static loading. This is a fairly old study and the source of one of my common like pseudo recommendations, hand waving, if you will, of try and vary your activity every 20 to 30 minutes. Too long in one place does stress the spine. And after surgery, for example, after a discectomy, I will tell patients try and vary your activity every 20, 30 minutes. Don't just sit for hours at a time because it can lead to fatigue. And that's when the spine's weak, is when these accessory structures will fail you. Another concept to add to that cone of economy is if you look at this cartoon of a spine, you see that the low back has a nice curve, which is offset by the chest, which has a nice opposite curve to keep the shoulders above the hips. And then if you just went from a straight line there, you'd end up way out of ahead of your hips with your skull. So instead, you have this nice curve in your neck to sort of put your head back over your hips. And this is all um, designed, if you will, to keep you in this balance, so you're not struggling to maintain or wasting unnecessary energy to just be upright. So, so she was right. Grandma, mom, they were right by telling you stand up straight, shoulders back, neck up. I Patients often ask, especially after neck procedures or for their neck in general, how did they help that? And I often joke, but half seriously, you know, book of poetry on top of your head, walk around like a lady, and I think you're kind of getting the idea. And the data supports that. Also, normal range of motion strengthening is also known to prevent injury. And again, this talk isn't necessarily for here's all the various exercises and how to do them. maybe a great topic for a physical therapy lecture, but there's plenty of media out there for you to consume on the subject, especially from reputable physical therapy sources, etc. And if you suffer from these issues, come to us and we'll set you on the path. Uh, um, for the lower back, also many of you have heard, aiding your low back by recruiting your abdominal muscles, recruiting your glutes and hamstrings when you're doing something, using good posture when you're bending, lifting, avoiding um, unnecessary loaded uh, weight bearing flexion and extension. Um, Poor lifting techniques is known to decrease lumbar events. And there's some good biomechanical data that shows, um, and we've actually measured intradiscal pressure in live patients um, in activities to know that that intradiscal pressure increases under load with poor positions. So um, you are stressing your discs. Um, and perhaps the worst of all of them, and I tell patients after a microdiscectomy, which is your disc is herniated through a hole in the disc in your low back, and we go in to remove it. For a good 3 to 6 month period, you're at an increased risk of a reherniation. So I tell you to avoid excessive BLT, bending, lifting, twisting, because those are the three positions that most stress the disc in its weakest places. So avoid BLT. And many of my recurrent disc herniations, which is thankfully a small number, but they've often recited for me when it happened, and it's often all three at once. I bent over while I was twisting to pick up my car keys, and as I stood up, that leg pain came back. So avoid BLT, especially after a procedure. Um, this is something I wanted to go over because it's a common thing for me, especially in a sporting environment. Um, this is only half serious. There is an actual DSM psychological condition called Munchausen by proxy, which is where parents sometimes create illnesses in their children in order to feel like saviors. So thankfully, it's ultra rare psychological pathology. But I think in our environment, I see this all too commonly in this well-intentioned desire to have our children be better athletes or to do these things that we enjoy in sport. And I'm all for it. Let's just get out in the open for full disclosure. I grew up in Lake Tahoe. I did lots of sporting activities, lots of crazy things growing up, and I'm not here to cast stones at a glass house. Um, However, I find myself more often in these situations adopting a classic pediatrician point of view that I am here to help um, educate and put in perspective our activities with respect to our health and our spines and our skeletons, and an orthopedic surgeon as well, not just a spine surgeon. So there's let me tell you, there's lots of things that can go wrong. And um, and I think what I would like to say to all the people who might be listening, who are out there with their families, is we should all think about these things as we're raising our kids and know that we have to, our children want to have a good life. They want to have fun, but we also want them to have safe, healthy fun. And we should all be prepared if it doesn't end that way for the consequences. So when you're teaching your 9 year old how to do a backflip, which, I know some people who've done that. I just want them to understand, like, look, my role as a provider is to tell you things can end badly. Do everything you can to make sure they don't. And ask yourself, is this something that if my child doesn't do, are they going to grow up healthy anyways? Are they going to grow up happy anyways? I think we all know the answer is yes. And so let's just um, focus on health, safety, fun, and safety. I'm speaking as a parent of two young children, so maybe I'm just in that mode, but I'm going to get off my soapbox now. Um, so I want to segue into now how um, normal spines work. And then we'll talk about how normal spines stop performing the way they used to. So don't worry, there's no quiz. I'm not trying to teach you the anatomy of the spine. But if you look at these charts, you can see there's a lot going on here. There's the bones that support the spine, the discs, which are like little bushings, which help us move and create space for nerves, these yellow structures that exit at each level so that they have a nice conduit to get out of our spines and not be impeded, pinched, crushed. Um, and then there's a whole lot of accessory structures that aren't shown, muscles, ligaments, the blood vessels there can masquerade also as problems. And this is equally true in real life, not just on a cartoon. So if you look at um, these MRI of a fairly normal cervical spine, you see those bones and the discs in between, the spinal cord running down the spinal canal with normal spinal fluid around it. And in this cross section, you can see how that's all purposeful to um, leave room for these nerves to exit, the spinal cord to run down the middle. You can actually, in this image, see the nerves exiting through the space, and then they'll run down the neck to the arms, shoulders, or wherever they're destined to go, but depending on level. I guess I labeled these for you. I'll go back to the last slide to show you on the left side of this image, which would actually be the patient's right. There's ample room for that nerve to leave, but an astute observer would notice there's very little room actually on the left side for that nerve to leave. And that patient may be complaining of left-sided radiating arm pain. The low back is no different, with one major exception. Um, Again, we have bones separated by discs and then spaces for these nerves to exit at each level, and they'll go down in a characteristic distribution. But the spinal cord ends at L1 typically. And so we don't thankfully have to deal with risk of spinal cord injury in the low back instead, or much of the low back. Instead, it's more nerve related problems and injury. And so here's that same set of images for the low back. And you can see how the bones and the discs and the canal, you can basically see where the spinal cord ends here. And then this wispy collection of nerves called the cauda equina, or Latin for horse's tail, runs down the canal and then exits at each level. So you can see on the cross-sectional image how a nerve is actually leaving on each side. That isn't labeled, but that's probably the L4 nerve, just based on my knowledge of the anatomy. Whereas now this set of images will show you the difference. Here on the left is ample room for the sac of nerves in bright spinal fluid. The exiting nerve, now this is probably the L2 nerve or L2-3 level. Whereas on the opposite image on the right, that space is occupied by thickened ligament, thickened bone, degeneration, for lack of a better word. And there's very little room for those nerves. And we're going to touch on this in just a minute. That is spinal stenosis. So here you can see nice wide open spaces for those exiting nerves. And on this one, very limited room. Um, so getting back to less nervous anatomy, there's a whole host of things that can be responsible for neck pain. And of course, we can all sprain, strain, injure our back non-specifically, but there are a host of specific things that can happen, and all of our spines have a destiny, a normal degeneration or freshness date, life cycle that's unique to us, and is handed down to us mostly by our parents. Um, so they can degenerate. The discs, which I just showed you, can no longer occupy a healthy space as these separating bushings, but instead get into the way of nerves and other things. Um, we can injure our backs as we age. Our bones aren't as strong; they don't maintain as much just inherent strength and can fail under more normal conditions. We'll talk about spinal stenosis, spondylolisthesis, sort of an advanced class, and we won't talk much about. And so, thankfully, the reason we'll spend less time on them is the vast majority of back pain and back problems are benign sprains and strains and need no attention other than a tincture of time, some rest, non-steroidal medications, etc. Um, and then a much smaller percent of the work I do or people I see have bona fide degeneration, which might need attention, which might need uh, an intervention or some multimodal treatment. Disc herniations, an even smaller percent. And thankfully, that's not a lot of you yet. Every Monday, Wednesday, I'm in the operating room, and a lot of that work is on degenerative herniated discs. Um, and you can see these other problems occupy a pretty small percent of the work I do. Um, so when it really gets your attention is a process called radiculopathy. Ask my wife; she'll tell you your radiculopathy. And to which I will tell her, no, actually, that's Latin for radic, which is root, and it's the root of the nerve that's the problem. Those exiting structures that I showed you coming out of the spine. Um, and when they do, they go into characteristic places. So this is called a dermatome, and it shows you where every one of those nerves will distribute its sensation. Um, Dermatomes are the sensation. So take any one of these, and you can see that impingement of, say, the C5 nerve will radiate out to your shoulder, maybe down into the biceps, whereas the S1 nerve will radiate down the buttock, down the back of the leg, straight down the back of the calf to the bottom of the foot. And they also do specific motor functions. So when I have somebody in clinic bring their wrist back and resist me, I'm testing the C6 nerve distribution. Whereas if I have them flex it, almost like they're making the number 7, I'm testing the C7 muscle because all these nerves have specific distributions. And when a disc herniation gets in the way, one of those nerves can become impeded. And so you can get pain and weakness and dysfunction in the distribution of that nerve. And so many times when people have these sporting injuries, they come in because of this. Because if you've never had nerve pain, you've never had nerve pain. Um, you don't know what it's like. And those of you that have are nodding your heads right now that Yeah, there's nothing we can tell you if you haven't had it. It's truly something to behold when you have severe burning, radiating, hot knife-like pain from a pinched nerve. Or you might be alarmed because it's just subtle. It's causing a numbness and tingling along the distribution of that nerve, and you don't know why. I get this just nummy ants crawling on my skin down to these two fingers because the C6 nerve might be pinched. Um, and here's another picture of that dermatome. And here's the same thing in the low back. People will commonly come in complaining of sciatica. And then I'll hone in on the fact that the sciatic nerve is a collection of nerves, L4, L5, S1, S2, even S3. Um, and they all will radiate in different distributions. So yes, they all come in with sciatica, but I will be listening for that's the L4 nerve. And so I'll be looking at the O4-5 level, or maybe even a little bit above as that nerve passes on its way out of the spine. And so these are the things we're looking for and assessing for in our examination. Um, I always try and work somehow into my talk the sinister things, the crazy things, not to freak anyone out, but to tell you just how rare they are. So when you have severe back pain, when you have crazy radiating arm and leg pain, um, pump the brakes, take a deep breath, and relax because it isn't one of these really sinister thing like cancer, like a spinal abscess or some syndrome that you never had all your life, but all of a sudden got, because these are really rare. Um, and so, um, thankfully, we rarely get into that. And we do look and listen for red flags. The first two images on your right are tumors. And then this last one is actually gout, which is a rare offender of the spine as well. And we look at that under a microscope to diagnose it. And then we have some masqueraders. So sometimes people come in, and again, fortunately, only a very small um, percent of the patients I see have some other issue that comes into my clinic as back pain, typically, or sometimes neck pain. But most of these issues affect the lower back, and they're organ disease or organ issues. And so we listen for those and we assess those, but again, thankfully rare. Um, and then the one thing that you might think I wouldn't have to say it, and I probably don't, but there is a problem which has real urgency. So much so that if you have this problem called Cauda equina syndrome, you need to get something done about it and quick. These problems, which manifest as weakness in the lower extremities, um, bowel and bladder incontinence, or maybe you're retaining your urine, can't go to the bathroom. Certainly paralysis would get everyone's attention, or numbness and tingling in the saddle distribution. That means that something is occluding all those nerve roots, especially the sacral nerve roots. And that usually is a large, massive disc herniation, but it can be more rarely some other things. And that is you need attention. And I know it probably makes sense that if you lose bowel and bladder function, yeah, you should go get that looked at and get it looked at soon. You have 24 to 48 hours to rectify that, um, or it can't be permanent. Um, and the things that we're listening for, and um, thankfully, you don't need to focus too hard. And that first one disappears because I really don't want you to focus on over 70. That's just a demographic risk factor, but 99% of my over 70 patients don't have these problems. But of course, it's more common as our spines age. But no back pain should be accompanied by fevers or chills or right after you had um, a tree branch go into your back. Now you're getting fevers, chills, and back issues. Those are all red flags to me. Obviously, recent trauma to your spine. Night pain's a specific one because people, so normal back problems, the ones that maybe this talk was devoted to, like biking, skiing, swimming, wakeboarding, whatever, they go away when you rest. Or at least when you lie down, they're better. And at night, they're not as much of an issue as they are during the day. But night pain that doesn't go away, day, night, whatever activity you're doing, that's a red flag. Um, Obviously, any actual bona fide motor weakness, you can't lift your foot, colloquially, a foot drop. That's a big deal, and you should get attention. Um, and then here's the symptoms of cauda equina, um, unexpected weight loss, and what I really mean is kudos if you're on a diet, exercising, and you lose 5, 10 pounds. But if you lose 20 pounds without trying, under no specific regimen, and you have back pain, that's a red flag. Um, you should see somebody. Um, and of course, the people with a strong history of cancer, they also kind of self-flag themselves. Sudden acute back pain with a history of osteoporosis also might demand your attention. Steroids create osteoporosis, among other things, and so they're another um, reason to take note. Same with immunosuppressive drugs, and chronic steroids are immunosuppressive, so um, other they're a setup for things like infection. Um, and if you're really trying to get a spinal infection, then IV drug use is a great way to do it. And uh, thankfully, even they really have to try. Um, and then one of the catch-alls is we see you and we get you into a multimodal, conservative, non-operative care regimen, and just not better. Well, that's when we escalate your workup. So most people in that 6 weeks of conservative therapy just get better and things go away. But if they don't, then it's still probably nothing. But we still probably should take a deeper look, get some advanced imaging, do a deeper dive. And then point tenderness is actually probably a bit overkill. Um, so you've injured your back, or all of a sudden you have tremendous back pain, neck pain. How common is that? Well, basically, within a year, 20 to 65% of us will have back pain. I frequently will say that patients have about an 80 to 100% risk of having back pain in their life that is severe, um, terrible, and unremitting. And so that's just the human condition. We all will get that. And it's just one of the most common things we do. And that's the number five reason to visit any doctor, not just me. So it's really common. Um, who gets these? Obviously, there's some obvious things like, oh man, NFL football players, power lifters, yeah, they have more back pain on average, have more problems than others, but um, those who, but but also don't necessarily have pathologic back pain. Um, those who can't keep that ideal body weight have a higher incidence. But believe me, I'm a sympathetic here. I know that's one of the hardest things to control. It's one of the hardest modifiable factors too. So people almost have to prod me in clinic into going into a dissertation on, well, how much would weight loss affect their back pain? Because it's really a hard question, first to put into practice, second to answer, because yeah, I see patients who are able to get down to an ideal body weight, shed a lot of extra weight, and now we live in the age of GLP-1 inhibitors and Ozempic. So there's there's real tangible help out there for people, but it's yes, it can help. I will tell you that. But is that something that I count on people being able to do to help themselves? Jeez, that's tough. So do your best. Um, More common is that we just don't take care of our backs and we're in kind of poor health. We're too busy traveling with our families or being spine surgeons to do what we need to do to be in optimal back health. Um, so yeah, it happens. History of low back injuries, yes, although having a back problem, having an injury is not a life sentence. Most people will return to absolutely normal lives. It's true that depression, anxiety are strongly associated with back pain and neck pain. Um, but all of these are trumped by who you are, where your spine came from. And so I frequently say, and this isn't strong scientific evidence because nobody can really put a number on this, but I would say 95% of all of your problems that you will come to my clinic for are um, hereditary. And so if you really want to blame something, don't blame that you used to be an active youth or you did a lot of sporting activities or whatnot. I mean, you can blame your parents. Doesn't do you any good, but that's probably your number one risk factor. So what do we do about this? Again, the first thing to do, pump the brakes, understand that most of it resolves and has a happy ending. Um, Remain active. There's some really great evidence that shows that you may not be able to avoid these things, but when they happen, people that remain active, that stay mobile, are doing their normal routine as much as they can through this terrible episode of back or neck pain, that their episodes are shorter in duration, somewhere on the range of 4 to 7 days as opposed to 1 to 2 weeks. And so you should try and be active when these happen. And then again, if that pain is associated with red flag, like I can't move my foot or my wrist, well, of course that's different, but try and be active through these episodes. The basic foundation of core conservative care is, yeah, some acute rest, but again, rest while maintaining some normal activity. Um, Non-steroidal anti-inflammatories, patients often turn to, but I will tell you often take inconsistently. So when I put somebody on ibuprofen or Aleve, two of the most common NSAIDs, I will tell them to take it ibuprofen 3 times a day or Aleve twice a day for 2 to 3 weeks, like an antibiotic with fudarin and acid to protect their stomach lining. And then it blocks the inflammation pathway biochemically in your body and keeps it blocked while the inflammation goes down. But if you just do it here or there, it's not going to do the same thing. Um, Ice, heat, whatever makes you feel better. There is some data for acute injuries that ice is better than heat. But if this is a recurrent problem for you, dealer's choice. Physical therapy, yes, that's what we'll send you to. Alternatively, the data is equally as good in the literature for yoga and Pilates. So that's a great option. Muscle relaxers, that's from us. So obviously you can't go out and just buy Flexeril, but if it rises to the level of seeing me, you'll probably walk out with some. And then maybe there are some more significant anti-inflammatories. And then no bad problem. Really, well, how do we avoid really bad problems? And that's by reassessing. So I expect most people who go through these episodes to get better in 2 to 4 weeks. And if they don't, then we bump up our threat level and we look deeper into it. Um, Technically, there's no good scientific evidence for X-rays. However, that's one of our sort of clinic things that if you if it rises to the level to see me, we'll get an X-ray to make sure we're not missing something, unless you already have them in the system. Um, and then if you don't get better, we take it further. Sorry about that. Because there's a motto which is motion is lotion. I know there's a lot out there, especially nowadays in every YouTube feed or whatever your TikTok jibber jabber, whatever, will have an ad for some spinal remedy. And if it ends up in my clinic, then it's got scientific evidence, but otherwise it's just as good as snake oil. Now, if it makes you better, doesn't break the bank, typically those things are pretty harmless. But what I will say is that motion is lotion, and the more you can remain active, the better, and it'll serve you well. Um, when do we uh, get advanced imaging? Well, first of all, we just said if there's a red flag, you have a strong history of cancer, there are other reasons for concern or suspicion, some of which we mentioned. And yeah, then I may kick that ball further down the field. But otherwise, um, if you have any of these things that we know to be a problem, or there's suspicion for other things, or you've just failed to get better with normal, good conservative care, then we should get some advanced imaging. Um, and when do you need me? Again, people sort of self-select. You need me when you have motor deficits, God forbid, that Cotta-Aquinas syndrome, um, when you have severe unremitting pain, neurologic pain, um, which again may sound like a ridiculous amount of pain, but it's radiculopathy. It's nerve pain down a nerve distribution. A great reason to come see me. Um, and then some of these things that, um, like we talked about, you may not know, but through these other symptoms, we'll know. Um, People know when they have spinal stenosis. And believe me, by the time I operate on something like spinal stenosis or a condition called spondylolisthesis, people know they have it. And we followed them over months, if not years, trying to work them through it conservatively. Because as every one of my patients will tell you, you get surgery when I get surgery, which is the last resort. It's never the first option. Not for me, not for my family, so it won't be for you or your family. So to summarize, there's just some take-home messages. Good posture, walk like a lady. Reduce your unnecessary stresses, especially in these repetitive loading activities or work. Um, do what you can to maintain ideal body weight and core strength. And bodies in motion, bodies that are strong or fit tend to do better overall than ones that aren't. So do what you can. And motion is motion. But don't worry, most of these problems are benign. Hopefully, I've kind of hit that nail enough times. Um, don't worry about ESR. Um, and again, um, relax, start with some non-steroidals, um, and know that, rarely does this get so significant that you need me, but we're here for you if it does. Um, all right, Natasha, did I keep you?
I'm here. Thank you so much. That was wonderful. Just as a reminder, if you
I
joined a
don't.
little bit late, you can ask questions. There's a Q&A box at the bottom of your screen. You can just hover there. You can ask questions anonymously, or you can enter them into the chat. So I'll look for those. I see a couple have come in already. So the first one is, what is the difference between complete and incomplete spinal cord injury and treatments?
Um, this is complex issue, but a relatively simple answer. And the short answer is a complete injury means no function below the level of injury. So if you, let's say, had a T10 burst fracture with complete spinal cord injury, you would have no function below the belly button and no sensation, no motor tone, anything. And if you have any of that, like if the patient has sensation in their big toe, it's an incomplete injury, meaning something's still getting through, and that's cause for optimism.
Okay, the next question is, can you talk about footwear as it relates to back pain? As an example, I wear heels most days to work. Is that going to create problems for me down the road?
So no strong data with respect to your spine. Dr. Ryan, my partner, who's a foot and ankle surgeon, certainly would have a lot to weigh in on all the maladies of the foot and forefoot, wearing heels and how big your toe box should be. In terms of your spine, I've really got no dog in that fight. I don't think I can give you anything scientific that would tell you if you do this or if you do that, you can save yourself from problems. So unfortunately, I can't give you a whole lot. So wish I could.
Can you discuss what a spine surgery recovery looks like, or is that individualized?
I can just sort of give you a broad brushed view of um, and there's obviously there's minimally we do the both M's in spine surgery, minimally invasive and occasionally maximally, depending on what's needed. We're all basically minimally invasive spine surgeons, but some people need a little bit, some people need more, but what they all want is a good result. So it just depends on what it takes to get us there. And there are some general rules of thumb. I mean, surgeries take anywhere from a half an hour to several hours, and maybe an outpatient, sometimes requiring even as little as a band-aid as a bandage, such as endoscopic spine surgery, which I do, um, or maybe just a small bandage because we did it through an incision that big with a microscope. Whereas some patients, and I'm one of the few in the region who do these big or global spine surgeries, might have a 30 centimeter incision and be in the hospital for several days. Yet, pain medications are usually required after spine surgery for 1 to 6 weeks, 1 to 8 weeks. The most states in the nation now generally want spine surgeons to stick within a 12-week period of prescribing medication. So thankfully, most don't need me up to that 12-week period prescribing medications. I would say these smaller surgeries, generally 1 to 3 weeks, 1 to 4 weeks. These bigger surgeries, maybe 2 to 6, 2 to 8 weeks of pain medications. Almost every surgery that I can think of, I want people up and mobilizing as soon as I can. So almost all my patients, even the big surgeries, will be up and out of bed the day of surgery and every day thereafter. And I'll usually prescribe walking at least 3 times a day. And for some, that means they're up to their normal activity soon, back to their work in as little as a week, 2 weeks, and then some maybe longer. And in general, we try to be your advocate. So I'll usually won't be the reason why you have to go back to work. We'll try and support you through the time that you need. Um, but again, that's as probably broad as I can be without getting into specific problems. Um, so, uh, yeah,
Great. It looks like this might be our last question, and we're right at the top of the hour. So I'll ask it. I'll look if you do have a question, you can try to ask it, and I'll ask it on your behalf. But the last one is, can you talk more about ergonomics when it comes to chairs and that sort of thing?
yeah, sure. Again, also, if we go back to that economy of motion or that cone of economy, basically, when we're sitting or standing, it takes the least amount of energy to stay that way by being upright. And so the more you can do to maintain that, the better. And the more that things that you're doing force you to be out of that, the more it should sort of, ring in your ear that I need to stand up straight, make accommodations, put my screen up, lower my chair, whatever it takes to sort of be, you know, front and center, confronting the world in a well balanced posture. Now, what that takes is different. One of those slides mentioned that a lumbar support often does help. Most people know that uh, modern cars all now have these like adjustments that can inflate in your low back to try and help fill that space, so you don't have to activate your trunk muscles while you're just sitting driving. Um, but um, but there isn't, by the way, a magic formula. And another common question that I get on a related note is pillows and beds and mattresses. And the reality is that I get the whole spectrum. Patients benefit, or patients will attest to, oh, I need a really soft pillow. I need a really firm pillow. I need a little Japanese pillow that I imported. I need Dr. X's miracle spine pillow. Again, there's no data. And my general recommendation is if it makes you better, not worse, doesn't break the bank, and you find that's your solution, then I'm fine with it. So I wish that um, there was data directed to that, and instead, I think it's just a reflection of people are different, and so um, uh, find those things for you, and uh, then you can figure out what it is that you need.
Great. Well, I think that's all I see question-wise. I'll just remind folks that this webinar was recorded, so it will be up on our YouTube channel and our Facebook page by tomorrow. And there is an exit survey that we love to hear your feedback on. How did we do? And what would you like to hear from us on in the future? But Dr. Child, I really appreciate you being here today. I hope you get back to enjoying your family vacation. And thanks, everyone. I hope you have a good evening.
Appreciate it. Thanks a ton, everybody who came, and Natasha.